So today the plan is to convey to you the principles, the basic principles that govern the management of clefts, be it lip or palate or the whole entire gamut or the complex. We're not going to look into the specific surgical aspects or the specific surgical techniques as such today. In days to come, if things go well, we will look into all that. The most important part of any surgery or surgical procedure is the basic principles and the ideas and the thought process and the philosophy that go behind the surgical management. And that's the most important bit. And that is unless and until that is absorbed very well, then you will not be able to manage any of those things well. So this is the most important part of the series of lectures. And this is something that everyone should absorb very well. The other point that I should like to emphasize in the preamble is this is not a master class or cutting edge of the latest management of clefts. By any stretch of imagination, it's not. This is a very, very basic talk, and the idea is to handhold people who are starting to learn or manage clefts and take them over to the next couple of steps or 3 or 4 steps so that they sort of start walking before they start sprinting. That's the whole idea behind this lecture. So if anyone is a great expert in clefts, probably it will not benefit them a great deal. Okay, so having got all that out of the way, we will get into the topic proper. So again, the bare basics. What's a cleft? Whether a lip or a palate, it's an abnormal separation in the orofacial region whereby the oral cavity or the lip is in abnormal communication either with the exterior or with the nasal cavity. Where usually when the mouth is closed, in normal circumstances, as you know, there is no communication outside or with the nasal cavity. But if you have a clefts of any variety, it can, protrude outside or go into the nasal cavity. Again, it's nothing to write home about. Everybody basically knows this. Right. The other thing is that is this a new phenomena or is it not a new phenomena? There are, diseases of the 20th and the 21st centuries like AIDS and the COVID and the coronas or whatever. But this is by no means a new disease. It's been existent right from prehistoric times. You look at the Peruvian sculptures, the Egyptian pyramids, and Mesopotamian civilization, the Indus Valley civilization. There are pictures depicting clefts in each of these civilizations. So this problem has been existent from the time mankind evolved. Is this a good thing or a bad thing? It all depends on your perspective. But the good thing is that because it's been an age-old disease, the pathophysiology behind this, the management protocol, the treatment protocol has been reasonably clearly evolved, and a good protocol has been established worldwide. So that's a good thing about having a disease that's been in existence for a long time. And my gamut is to sort of make it very clear what has this protocol that's been established down the decades or the centuries. Where does it all start? As you all know, it all starts in the embryo, and the development is in the early 3rd or 4th week. You have a frontonasal process and a maxillary process and a mandibular process. Again, nothing very complex or complicated. Everybody knows about it. And when these processes fail to join together, you have a cleft or one variety or the other. So there are basically 2 theories behind this. There's a classical theory of Darcy, or the mesodermal penetration, or the impenetration theory of Stark. So how does this work? Usually you have the frontonasal and the maxillary process coming in together. First, the ectoderm and the endoderm fuses, and then the mesoderm penetrates through this fusion of the ectoderm and endoderm, and the fusion is complete. In the classical theory of Darcy and Huss, the processes you do not fuse at all. So it always remains separate. The mesodermal penetration theory says that ectoderm and endoderm fuse in all circumstances, but the mesoderm fails to penetrate through, and the fusion of the ectoderm and endoderm is not strong enough, and that breaks down as a result. What's the proof? The proof is that if people have dealt with clefts, know the existence of what is known as Simonard's bands. What is Simonard band? It is a skin bridge in the middle of a cleft. So only the skin bridge exists. That means the ectoderm or endoderm is fused, but there is no muscle going through. And the existence of Simonard's band is the proof of the mesodermal penetration or the impenetration theory. So you can take your call on which one to believe. You can either believe in the classical theory or you can believe on the mesodermal penetration or the impenetration theory. Right. How common is this? See, all these things would appear very, very boring because it's basic statistics, but exams are bad things and examiners are even worse people. And they have this knack of zeroing into these inconvenient home truths and ask you these sort of questions. And if these things, and if these basic statistics are not at your fingertips, then the exam may not really go the way you want it to go. So you don't have to digest or swallow a huge amount of statistics, but the basic things it's better to have under your belt so that you will not land up in trouble later on. Okay, anyway, here goes the boring bits. In the West, the incidence is about 1 in 750. That means if there's 750 live healthy children being born, one of them would have a cleft. In our part of the world, the incidence is around 1 in 350 to 400. That means the incidence is almost double. And in the southern parts of the state, I don't know why, in southern parts of the country, it's supposed to be extremely high. The reason behind that is not entirely clear, but there have been, as usual, various postulations. Okay. Predominates in the males, but cleft palate alone common in the females. In the unilateral cleft lip, the left side is affected in the vast majority, 60% of case, the left side. Here you can see left 6, right 3, and bilateral 1. That is the basic ratio. And again, if you look at isolated problems, cleft lip and palate predominates, about 46%, followed by isolated cleft palate, which is 33%, and isolated cleft lip is the minority in 21%. So these are things that you should have a basic idea on. I agree, it's boring, and you might think it serves no particular purpose, but then the trainee or a junior, it's a good idea to know all this. Right. Why does this happen? When people are not sure why things happen, there are a number of postulations because no one is very sure why this happens. And obviously, genetics is something that's always blamed, or if that doesn't fit the bill, environmental factors are blamed. So there's a genetic predisposition, especially if there's a family history of clefts in the family, then the incidence is much higher. And various environment factors are implicated, like epilepsy, German measles, drugs, maternal malnutrition, vitamin deficiency, consanguinity, etc. But if a parent comes with a child and asks why my baby had this cleft, it's extremely difficult to put your forefinger and point out this is the exact reason why this happened. You would think that's a normal child and a cleft is just a gap in the lip. But if you go down to the anatomical basis, there are a lot of things in this particular area that's cleft. When things are cleft, obviously there's a breach in continuity. Not only is there a breach in continuity, but the attachment gets skewed. So instead of forming an absolute ring around the oral cavity, the whole structures are cleft, one, and they are attached abnormally. And when they're attached abnormally, they tend to pull in all sorts of abnormal directions. And the resultant deformity is a complex issue of the gap, the abnormal attachments, and the secondary effects due to everything pulling in all sorts of abnormal directions. You can see here the orbicular is also split. Not only is that split, instead of forming a ring around the oral cavity, if it is attached to the columella, it is attached to the alar base, the zygomatic is major, the zygomatic is minor. See, it's pulling like this. Here, the attachment is abnormal and the pull is abnormal. And there are all other muscles like levator labial superior, aliquinae, levator labial superior, etc., 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 which are all attached abnormally, split abnormally, pulls abnormally. And what you have to understand is that the abnormal pull and attachment does not happen at the time of birth. As I told you, the whole thing, the abnormality happens the first few weeks of pregnancy, and you have got a good 8 to 9 months of this abnormal pull acting on the face of the baby before the baby is actually delivered. So all the deformities would be reasonably well established when the baby comes, because it's been all been pulling for 8 to 9 months in abnormal directions. Right. So this is the picture that all budding, established, and senior cleft surgeon should have in their mind. What is this picture? This picture is about, this is called a worm's eye view. This is about a worm sitting on the lower lip of a person with the mouth wide open. And a worm sitting on the lower lip, if the mouth is wide open, what do they see? At the top, they see the dome of the nostril, and say they see the nasal apertures, the columella, the upper lip, the alveolus with the teeth, the anterior palate, the incisive foramina, the hard palate, and the soft palate, and the uvula. So you have to use the imagination and consider this as a worm sitting on a lower lip with the mouth wide open, and the worm is looking up. And this is the picture that the worm is going to see. And this is where all the classifications and all the tables and the statistics come based on this particular picture. And now, from now on, when you talk about the cleft and the anatomy, this is the picture that you should definitely have formed in your mind. Right. Again, as I said, we talked about the lip cleft in brief. When the palate is cleft, see, it's not only that there's an opening in the middle, but the muscles are all abnormal. You can see that the hard palate and the soft palate. And the soft palate, the levator velae palatini and the tensor velae palatini are the most important muscles of the lot. The levator does the bulk of the work. And what happens in the cleft, not only is everything cleft, instead of the levator forming a sling like that and pulling the soft palate and the uvula up onto the pharynx, what happens is the muscle is cleft, and not only is it cleft, it's attached abnormally along the back of the hard palate and the edges of the cleft. So the pull is also abnormal. So that's the abnormal morphogenesis and the pathophysiology in a palatal cleft. All these things we will discuss in detail in coming days or weeks or when the time comes. But the basic things are, these are the things that you should have in mind. Right. Everybody thinks, okay, you have a cleft lip or a cleft palate, and that is the be all and end all of it. Technically not. It comes in a wide variety of bizarre presentations. You can see here in cleft lip, in isolated cleft lip, we can have it a complete one like so, an incomplete one like so, a unilateral one or a bilateral one, or with or without a cleft alveolus. So as cleft of the lip alone presents in so many various ways. And the palate, you can have a cleft of the soft palate alone. You can have a cleft of the soft and the hard palate. You can have a unilateral right-sided cleft, or you can have a midline cleft, etc., etc., etc. And then to confuse things, you have got suboptimal or not full-fledged expressions of the cleft. It's called a form thrust or a form frost of the cleft lip. What does the term mean? Term form frost means that it's an incomplete expression of a whole. As you all know, the complete expression is a total complete cleft of the lip and the palate. That's a complete. So these form frosts are incomplete expressions where you sometimes get just a notching of the nose, a small scar here, or a notch on the vermiglion. There will not be any gaps. But even that forms a cosmetic deformity, and sometimes they need to be repaired. What are the form frosts of the palate? The submit of cleft palate. There is actually no real cleft, but the muscles have not grown across. So we'll end up with a VPI anyway. And what are the indications? You have a bifid uvula. You have got a translucent area here because you have only the mucosa there and there are no muscles going across. And there's a notch in the back of the hard palate. And these are form of expressions of the lip and the palate. So as I said, it presents itself in a wide variety of confusing, bizarre permutations and combinations. Right. As I told you, this is the picture that you will have in mind, a worm's eye view. And all the classifications are based on the worm's eye view. The standard internationally accepted classification is the Carnahan's striped Y, which is which expresses all different varieties of permutations and combinations of the cleft lip and palate, and it's a complete expression of all the varieties that can present itself. But in India, we tend to follow to a certain extent the NARCO classification. Why do we? It's a very simple thing. You know, craniofacial CFC is craniofacial cleft. One is lip alone. One is lip and alveolus. Two is cleft of the palate alone. And three is cleft of lip and palate. Very simple, very simplistic. But what's the negative problem? What the drawback of this is that all the combinations you will not be able to be represented in this simplistic classification. Why do we follow this? Because this was designed and propagated by the father of modern plastic surgery in India, Professor C. Balkrishnan. He started his career, his unit in NARCO. That's why it's called NARCO classification. And then he moved on to the PGI later on. Because it's on our own classification and because it's simple, people tend to follow this in India. But internationally, it's a Carnahan striped Y that's followed. And just a few minutes on what it is. As I told you, this is the picture you should all have in mind. Worm's view, worm sitting on the lower lip, mouth wide open, and worm looking up. And this is what you see. And this is exactly what is represented in the Carnahan striped Y. So you look up, what do you see? You see the nose. And it's divided into the nose and the nostril floor. That's one. And then what comes after that? The lip comes after that. There you are, right lip, left lip. And then the alveolus. You have the alveolus here, right and the left. And then you have the anterior palate or the primary palate. Again, a very basic, simplistic thing. I am sure everybody knows, but for those who do not know this, the differentiation between the primary palate and the secondary palate, or the anterior palate and the posterior palate, is the incisive foramen. That's where the embryogenesis comes in, and above the incisive foramen is the primary palate, and that's what is represented there, the primary palate. And then the whole of the secondary palate, anterior 2/3 are hard, and then the soft 1/3. You can see here, hard palate, and then you have a soft palate underneath. So the whole picture based on the cleft is represented in the Carnahan striped Y. If you have a right a nostril ALR notch, you can just shade that. If you have a lip cleft on the right side, you can shade that. Or any combination. Or if you have just a soft palate cleft alone, you can shade this alone and leave all the other things out. And if you have your alveolar cleft alone, you can shade that or what. So any permutation and combination that is existing can be represented in this column and striped white. Very exhaustive. It's actually a very good classification. This is something that you should know in and out. Right. Everybody says, when should the management start? As everybody knows, common sense that all congenital problems should be managed at birth itself, and you should start managing at birth. But obviously, technology has grown, mankind has known, innovations have grown. Now we have to start managing clefts before birth and before they are born. Why? Because there is antenatal diagnosis bright and early about whether the baby has got a cleft or not. And the parents, rightly so, gets frantic when the phonologist or the gynecologist tell them that the baby's got a cleft, and they are frantic and they come running to you and ask you what can be done. So nowadays, the management begins before birth and not at birth. See? And the management of clefts went through a phase of fetal surgery where people did a hysterectomy and started repairing the clefts. The idea behind that was that, as you know, fetal scarring, fetus heals without scarring, and people thought that if you do a surgery in utero when things are bathed in amniotic fluid, then everything heals without a scar. But then that's not in vogue now. The disadvantages outweigh the benefits, and people no longer follow the fetal surgery these days. Right. Okay. Again, the standard question, the world has developed a great deal, and there are specialists, there are super specialists, there are subspecialists, and there are super subspecialists. There's a huge variety, there's a huge spectrum of specialists specializing in all sorts of things. So the standard question that arises is, who or which specialty should manage this? Everybody has got a different take on it. Some people say, if you're a plastic surgeon, you would say the plastic surgeon should manage clefts. If you're a maxillofacial surgeon, they would say, oh, it's our priority, our territory, and we should be managing clefts. And there's a huge range of other specialties that pitch in and lay claim to the management of clefts. In an ideal world, if your aim is to deliver the best possible care and the best possible result to the cleft baby, then the cleft should be managed by all these people together. And only then an optimal outcome is possible. The surgical spectrum, you should definitely have a plastic surgeon and an oral maxillofacial surgeon supported, of course, by the anesthesiologist. And the medical side, you should definitely have a pediatrician to manage. And then, of course, you should have orthodontist, stroke, pedodontic service available, a speech therapist, and to support the child, a psychologist, social worker, and a nurse coordinator. In the Western world, you have the whole team sitting in a room and you have one baby coming across, and in a forenoon session or an afternoon session, you might at best see 5 or 6 babies by the whole team together. It might seem a great waste of time, but you can imagine the quality of service or the cutting edge service that is given to the baby when all these specialists sit together and look at one baby and manage the cleft. Obviously, in our part of the world, I don't know how practically possible this whole scenario is, because it might seem a waste of time to a lot of people. But the lead person, there has to be a lead person, and that lead person should take the honor and make sure that all these people are involved in the management of the baby right from day one. And if that is not possible, your outcome is definitely going to be suboptimal. Obviously, here the social worker and the nurse coordinator possibly and probably do not exist. So the lead person will not only have to be the surgeon, they have to be the social worker and the nurse coordinator also. So it's a teamwork, it's a team game. Why? A lot of anatomical areas are involved, a lot of functions are compromised, and so unless everybody pitches in together, the outcome is not going to be optimal. Right. So I again told you a pictorial representation of the various varieties of clefts. You have incomplete cleft, you have a complete cleft, you have a bilateral cleft, where one side is complete, one side is incomplete. There's a complete cleft of the palate, the bilateral cleft that's incomplete, bilateral cleft where one side is complete, one side is incomplete. You can see bilateral cleft where the alveolus is cleft on one side, but just a soft tissue is cleft on the other side. The bilateral complete cleft going all the way through, a bilateral cleft with a prolabium and a premaxilla high up in the sky. So this sort of gives an idea of the difficulty and the variety and the different ways in which clefts presents to you. Right. As I told you, the problem or your intervention starts at birth or sometimes even before birth. The family, especially the parents, are shattered and bewildered. They have no idea what to do. Why? I am sure that anyone who is married and has a child would probably agree to me that the best part of their lives are when you are expecting your firstborn to arrive. You wait eagerly with a lot of anticipation, a lot of happiness in your heart for your firstborn child to come. And suddenly, a cleft baby arrives. And the parents come and tell me they feel that the sand is sifting from under their feet and they feel that they're falling into a huge, big cavern or a hole without any escape route. And that is exactly what they feel. They blame themselves and they are anxious about the future. And it is your job as a treating physician, you might be a surgeon or a hoof operative, but basically we are all physicians and our job is to console and comfort the sick and the needy, and you cannot escape that role in this area also. It is your role and your duty to tell them the truth, at the same time give them a rainbow in the cloudy sky and tell them that okay, there are a lot of problems, a lot of things need to be done, but at the end of all that you're going to have a good, happy, near normal baby. And this is how I always pitch my battle plan across to the patients and to the parents and to the family. But what are the commonly asked questions? Why, and why? Is it going to happen again? What are the other problems child could have? What are the is it going to be handicapped? Is it going to be abnormal? Is it going to grow up into a monster? What treatment can you offer? And more importantly, what's going to happen to my child? How is he going to fare? Is he going to be normal? Is he going to be abnormal? How is he going to grow up? What is his future? And these are the things, this is a theme that is commonly echoed and re-echoed time and time again. And it's your duty to give them an overview of everything and give them a rosy picture at the end of all that. And the treatment or the management is split into various time groups, okay? From birth right down to 18 years or to adulthood. And there are various key areas whereby various things are delivered. We will go and have a look at each of these in a minute. Right. The child is born, the child comes to you. The first thing that you do, you obviously as a clinician, you do a thorough physical examination as to the type of cleft. And as a plastic surgeon, your area of expertise or your ability to elicit problems probably stop that. Again, all of everybody, it's commonly known or it's popularly known that we surgeons are very simple souls. Our intellect is definitely limited, and our ability to assess complex problems and complex syndromes is very low. And, I am no exception. So I look at the cleft, I will then look at the baby, and that's all that I probably would be able to elicit. But it's extremely important that you know what are the syndromes that the child might have. As you all know, there are umpteen number of syndromes associated with cleft. We cannot go into all that because then the lecture is never going to finish. But you should know that. And you should have a partner, a pediatrician, or a neonatologist as your right hand to be able to examine the child and tell you whether the child has any other problem. Does it have a cardiac problem? Does it have a renal problem? Does it have a neural problem? Or anything else? And this should be realized bright and early. And if there's any life-threatening problem, that has to be sorted out. Cleft is not an emergency; it can wait. So you have to rule out all these, and only a very well-trained pediatrician or a neonatologist will be able to help you with that. And what do you tell them? You tell them the positive family history. Then there's a 1/3 chance the family history, and 2/3 chance the environmental factors are to blame, and these are the things that could have contributed to a child having a cleft. And this is the chance of the next child having a cleft. It's very complicated, but if somebody very intelligent wants to have a look at it, this is the picture that you give them. What are the chances of your subsequent children having a cleft? Just give you a second so that you can look at it. Okay. Right. So what are the problems? So when a child is born and comes to you, the basic problem is the feeding. If a child has got a cleft lip alone, the problem is only cosmetic, nothing else. But if the child has a cleft palate, it's hidden inside. If the child does not have a cleft lip, only a cleft palate, it's hidden inside. But the functional problems are more. So what are the problems? Child will not be able to suck well and would end up with a malnourished child. Child have, especially if it's born with a receding mandible, the so-called Pierre-Robin syndrome, child could have a respiratory distress. Can have respiratory infections because everything is open. It can because the abnormally functioning eustachian tube, the child can have biliary problem leading to deafness, and the other problem. So we tell the family and the parents in a very mild, underpished manner, these are the problems you might have to face, and then you tell them the treatment is for a lifetime, and at various periods, various surgeries would need to be done. And you look at the airway, and if there is an airway problem that needs the care of a trained neonatologist, if there is obstruction once in a while, maybe it can be managed by prone sleeping and prone feeding. But sometimes the obstruction is severe and can even produce a cord death. So people do nasopharyngeal intubation. People have gone on to tracheostomies. But in our part of the world, we resort to a tongue lip adhesion. It's an extremely efficient way of managing hypoxia or respiratory obstruction because of the clefts. But for some reason, it's frowned upon in the West, and they manage with nasopharyngeal intubation, nasopharyngeal tubes, and prone positioning. But in my experience, tongue lip adhesion is given extremely good results. And then the first major problem is airway, and the second major problem is the feeding, because the child will not be able to suck well if the child has got a cleft palate. But if adequate nutrition is not given, child is not going to thrive. There will be malnutrition, predisposition to infection, and of course your surgery is going to be delayed. breast milk, even if it's a single drop, should definitely be given because there is nothing more precious than that that's available. But chances are that you will have to start on supplements bright and early. There are various ways whereby the parents are taught how to feed the child. Again, I am not an expert at this. I seek the help of my friendly neighborhood pediatrician to help me at it, and they do an extremely good job, and that's where the teamwork comes into play. And there are various sort of bottles that are defined, which is supposed to help. But in my practice, usually you really don't need to resort to all this because good advice and good portioning usually suffices. Spoon feeding, bigger teats, QC bottles, etc., etc. Usually that takes care. So respiratory problem and feeding are the major problem that has to be sorted out, and the various modalities. And then again, you say there are various syndromes, and you need a thorough examination by the pediatrician to explore all the other congenital problems by the pediatrician, so that any other syndromes or complex problems are unearthed. And then comes the question of pre-surgical orthodontics. Again, if you have a pre-surgical, if you have a pedodontist or an orthodontist who can help you with the pre-surgical orthodontics, it's extremely useful. It makes your life so much more easier. So, well, what's the problem? You have the greater segment and the alveolus riding high. You have the cleft side, the lesser segment riding low, and the wide cleft and nostril is pulled down badly. It's going to be extremely difficult at the time of surgery to balance out all this. If you have someone delivering pre-surgical orthodontics, I can pull the lesser segment up, pull the nose up, then doing the repair becomes so much more easier. See, again, something like this, a bilateral lip with everything pointing at the sky, you will definitely not be able to repair the lip. So pre-surgical orthodontics, if there's around, it will be huge value addition to the team. So these are the various techniques that I use. Again, I'm not an expert at this. My partner, my colleague would deliver this for me. We are all specialists and experts in different areas, and we all have our areas of expertise, and it's better to stick to that. And there's something that we don't know about, it might not be a good idea to venture into it. It'd be a good idea to let them help you with that. So these are the things that are usually used. Okay, and when do we operate? There's no universal consensus. The standard rule is in a rule of 10, as you all know. But the standard accepted rule is you do the left lip at around 3 to 5 months. You need to have a HB of above 10 grams and a weight of greater than 5 kilos if possible, according to Indian standard. So the first 3 months, what do? To sum up, you counsel initially, you get a good pediatric care, looking at the feeding, the weight gain, control of associated problems, especially respiratory problems, pre-surgical orthodontics if it's available, review every month, get the child fit and fighting, ready to face the challenge of the surgery, adequate hemoglobin, and get the child ready for surgery at around 3 to 5 months of age. And that is what the first 3 months are all about. Even during the first 3 months, I've told you how many specialists are involved. The pediatrician takes the pride of the place, followed by the pedodontist, and the lead surgeon may be plastic or maxillofacial, who would act as the pivot around which the other specialists rotate. Okay, there we have looked at first 3 months. What happens after that? At about 3 to 5 months, we do the lip repair. So convert that to this. I'm not going into detail now because that's not the scope of this presentation. The scope of this presentation is just the fundamental principles, and that's what we do it at around 3 to 5 months. And there, After the repair, what do? You have to look out for edema because of the mouth swelling and there might be respiratory problems. You take care of the suture line, keep the infant in a proper position to aid feeding, and feeding can be started the same day, but you have to make sure that the sucking is avoided for about the first 4 weeks. So you usually spoon feed, or you give in a glass, or in a filler. Arm restraints to make sure the child doesn't pull on the lip. And the late management is important. Remember, surgery is only 50% of the game. The rest of the 50% is what happens after your surgery. You can end up with a scar contracture, you can have a hypertrophic scar, erythema, firmness, etc., etc. You teach the parents and the family to massage the scar about 2 weeks after the surgery, and the sutures are removed on day 5. You wait for another week. At about 2 weeks, you tell the parents that you have start massaging really hard. Otherwise, your scar, however well you've done your surgery, is not going to be adequate. So that's what happens at about 3 months of age. And you can see in the overall scheme of things how small surgery is. It's just one small fragment of the whole jigsaw. And then again, the surgery is passed. At about 3 to 12 months of age, you repeat the cycle again. Intense close monitoring by the pediatrician and plastic surgeon, along with your orthodontist or the pedodontist, to make sure that the child thrives well, feeds well, and make sure you work the child up and get him fighting fit to be ready for the palate surgery at around 1 year of age. So that's what happens. At the third phase, that initial counseling, workup, ready for lip surgery. You do the surgery, and then again, close follow-up, get the child ready for palate repair, and at about 10 months to 1 year, you do the palate surgery. There you are. Sorry. That's what you do. You close the palate. Again, the details will come to later. Again, post-op management is important. Airway management, because we have a huge gap, therefore the airway is big, but you have closed everything, and airway is going to be a problem. Make sure child gets adequate pain relief, arm restraints, and you make sure you follow up and closely monitor the child for 48 hours to make sure that a respiratory obstruction does not happen. So there we are. That's where the surgery comes in. You do the palate surgery at around 1 year of age, and then the next phase is a longer phase, 1 to 5 years of age. There we are. Again, you follow it up closely by the lead surgeon, by the plastic or max packs, closely monitored by the pediatrician to make sure the milestones develop properly. The orthodontist, the pedodontist sees well, clinical photographs are taken. But the two important things in this phase is the speech therapist and ENT surgeon who monitor the speech and the ear. So all these specialists slowly fade a little bit in the background, and these are the two specialists that takes predominance. Why? The problem in between age and 1 and 5 years is basically two. All the holes are now closed, child looks reasonably well, but the new problem that creeps in is inadequate speech, nasal speech, and inadequate hearing because of the eustachian tube problems. Here we are, the eustachian tube. The muscles are attached and the muscles are abnormal in the cleft palate, and the middle ear does not drain properly, and you can end up with abnormal eustachian tube, secretory otitis media, chronic secretory otitis media, and then deafness if it is not picked up earlier. So you need to have a close follow by the ENT surgeon. And if in case, unfortunately, otitis media develop, you do a laryngotomy, insert a grommet, and the ENT surgeon takes care of all that. And as a maxillofacial or pediatric surgeon, your knowledge about the ENT and the ear is quite minimal, and you have to have the help of your ENT colleague to properly manage this particular aspect. And speech disorders. Why? Because the muscles of palate do not move well. You can have velopharyngeal incompetence, nasal speech, as well as misarticulation or errors in articulation. And the speech therapist comes into play. You have to tell the parent the child needs to have proper daily speech therapy from the age of 2 years to 5 years. And only then the child is going to speak properly. Child will speak anyway, but the quality of the speech is going to be horrible. And unless speech therapy is given, child is not going to speak properly. So that is all that is done. Proper follow up by the pediatrician and the lead surgeon, but with special emphasis on the hearing, the ear, and the speech. At 5 years, we take stock. How is the child at 5 years? And what is this magic of 5 years? The magic of 5 years is the child is going to school at 5 years, and we do not want our child to be ridiculed or made fun of in school. You might think children are very, very small, but children can be exceptionally cruel, and the emotional scars that are inflicted on a 5-year-old child can last the whole of the child's lifetime. So we need to make sure, it's our duty to make sure the child's problems or deformities or disabilities are minimized or minuscule by the time child goes to school. So we make sure the child speaks well, child hears well, there's no ear problem, and there are no secondary deformities. If any of these problems are there, you need to correct that. How do we do that? Child has got nasal incontinence, you do a pharyngoplasty or a palatal re-repair to make sure that that is taken care of. In spite of your adequate speech therapy, if this is happening, you need to resort to surgery to correct that. There we are. It can be midline pharyngoplasty of the pharyngeal flap, or we can have a lateral sphincter pharyngoplasty. Again, we don't have time to go into that in detail, but these are the principles. And if the child has got visible problem, the lip or the nose, you do an appropriate lip revision, and you do a nose revision at that particular time to make sure the child looks good and proper. So that is what is done at around 5 years. The speech, the hearing, and the external deformities are all corrected, and child goes to school as near normal as possible. The emotional scars are minimized as much as possible. The next phase kicks in, which is 6 to 12 years, where the dental surgeons takes predominance. Because by this time, the milk teeth would have fallen out, and the secondary dentition would start coming in, and the secondary dentition needs to be optimized before it starts erupting. Because if it doesn't erupt or it erupts abnormally, then the battle is actually lost at that particular point. So you need to take the help of your orthodontic colleague, adequate orthodontic assessment, and if they tell you, you might have to help him with an alveolar bone graft to plug the holes and make sure the secondary dentition properly comes in. Whatever is needed, the teeth alignment with expanders or by teeth wires or ABG as and when is required. So you can see examples of that. And again, I have no clue about all this, but I've got a good orthodontician, my friend, my partner, who helps me deliver good results on this aspect. And if there's a gap, the orthodontic surgeon tells me this is the time to put in bone graft, and I put in bone graft at that particular point. Again, you need to work in tandem. Mutual help, mutual respect should be the theme, and only then things work well. You see, around 7 to 8 years is the time when an ABG is done. And then when the teeth is normalized, the final phase kicks in around 13 to 18 years of age, where definitely the maxillofacial surgeon takes predominance, and the retruded maxilla or the protruding mandible is set. You either need a unimaxillary or a bimaxillary osteotomy, and you reface everything, and the final lip and nose corrections are done at that particular point. Any psychological support, social support, psychological support is given to eliminate any residual emotional trauma or scars at that particular moment. And so this is the algorithm. The neonatal orthopedics or orthodontics, pediatric support. 3 to 4 months is repair. Again, from 4 months to 12 months, you prepare the child, work the child up for a palate repair. About 12 to 14 months, you do a palate repair. 2 to 5 years, speech and ear checkups. And then at about 4 to 5 years, you make sure your speech and ear is okay. The speech is not okay. You do a pharyngoplasty and all the secondary revisions. But 5 to 10 years of age, orthodontics, alveolar bone grafting, and any lip revisions. And finally, at about 12 to 18 years, orthodontic surgery. And at the end of all that, final correction of the lip and the nose. And that, ladies and gentlemen, is a full, complete story, right from birth all the way to 12 to 18 years, every particular landmark and all the specialists that are absolutely, totally necessary, who should be working in tandem, should be working hand to hand, and there's no prima donnas here. Everybody is important, everybody is great in their own respect, in their own right, and unless everybody works in tandem together as a great team, the outcome is going to be far, 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 far suboptimal. And that is again the pie chart. So to get from there to a cool, slick teenage child is the whole aim. Jokes apart, your aim is to convert this cleft child with a lot of physical, functional, and emotional baggage into a child which is confident, happy to go out and face the world, face the society on an equal footing with any other child. And that is your role and responsibility as a cleft surgeon. Thank you for patient watching. Thank you for patient hearing. If there's any doubts or queries, then I'll be more than happy to take it now. And thank you for coming late at night and spending the time with me the last 1 hour or so. Thank you so much. So,
thank you, sir, for such a elaborate lecture. Any questions from the audience to Dr. Krishna Kumar, please? You can unmute and ask him.
oh, thank you.
Stop it. That is.
What other questions? Okay, this is put. All these things are put at the beginning. Is there anything that anybody wants to ask, or any clarifications or any comments, or if anybody wants to add anything on, this is probably the time to do that. All right, Tessier classification. The Tessier classification is totally another issue altogether. It's a different ball game, and that although it says clefts and craniofacial clefts, our cleft lip and palate management is confined entirely to the group 3 Tessier cleft, which happens along the peripheral ridge. The other areas are involving craniofacial surgeries, a craniofacial surgeon, and the philosophy, the principles, etc., are totally, completely different. If you so desire, we can sort of think about that in a separate lecture or a separate time, because that, books and books of volumes are written on that. I don't think that we will be able to sort of discuss anything in a meaningful fashion today about Tessier cleft. Basically, this is part of a Tessier cleft. It's a group 3 cleft. That's what our standard cleft lip and palate is.
So, if there are no more questions, thank you so much, sir, Krishna Kumar, sir, for your effort and time. And we shall see you again soon for the next lecture.
Yeah, okay. We'll be in touch. Thank you, Dr. Krishna.
Thank you. Thank you so much. Thanks. Thank you. An excellent lecture. Thank you.